DILI in anti-tubercular treatment, current challenges. Introduction. Tuberculosis, TB, remains a significant infectious disease across much of the developing world. India is home to a fifth, 21% of the world's TB population, and the country with the highest TB burden. In 2012, the incidence of TB in India was 2,590,000 cases, contributing to more than 300,000 deaths annually, including 1,000 deaths every day. In TB, primary infection with Mycobacterium tuberculosis leads to clinical disease in only approximately 10% of individuals, and in the rest, latent TB infection develops. In 5 to 10% of latently infected persons, the infection reactivates and causes active TB. The progression from latent infection to active disease depends on several factors, of which the most important is the presence of an underlying immunodeficient state. Risk factors. Meanwhile, the incidence of TB DILI in the population is unknown and is probably unrecognized. Interactions between genetic, host and environmental factors contribute to the development of TB DILI. The following summarizes the most important factors. Age and gender. Organ involvement, extent of TB disease. Malnutrition. Alcohol. Hepatitis B and C. Genetic polymorphism. TB DILI. Toxicity and a subsequent insult to the liver can occur during primary prophylaxis, preventive therapy, and treatment of tuberculosis. It is also dependent on the dynamics of drugs, drug disease, and drug-host interactions. Most cases of DILI are idiosyncratic in nature, meaning it is the characteristics of the host and not the characteristic of the drug which is responsible for liver injury. Idiosyncratic reactions may be hypersensitive or metabolic. Out of these two subtypes, TB DILI is caused due to metabolic idiosyncrasy. Hepatotoxicity, the major challenge. But recent evidence indicates that drugs taken in quantities of more than 50 grams per day are more likely to produce hepatotoxicity, which results from the formation or reduced clearance of toxic metabolites. Among the first-line drugs, isoniazid, rifampicin, and pyrazinamide have the potential for hepatotoxicity, with pyrazinamide being the most hepatotoxic, followed by isoniazid and rifampicin. Rifampicin combined with pyrazinamide is more hepatotoxic. Pyrazinamide contributes significantly to acute liver failure. However, when DILI occurs following the use of a 4-drug combination regimen, it is impossible to quantify the contribution of each drug in the development of DILI. Other major concerns associated with the potential hepatotoxicity of anti-tubercular drugs are: first, in the setting of pre-existing liver disease, the likelihood of developing drug-induced hepatitis may be higher. Second, the outcome of drug-induced hepatitis in patients with compromised liver function may be poor. Third, monitoring of drug-induced hepatitis may be confounded in the presence of underlying liver disease due to fluctuating liver function tests related to the pre-existing liver disease.